In this chapter, we're going to talk about the different settings that psychiatric care is given in, such as your inpatient and your outpatient. Also, too, don't forget that we will have a guest speaker who will also be covering some of this as well. To give you some background information, you can look into the different social influences on the different types of psych care settings. So you can review the acts, so you have some type of idea of how the mental health care has changed over the years. Also, you can look at the vignettes that can relate to examples to the different acts. As we talked about in 106, the prevention strategies that go from primary, secondary to tertiary, just like in the medical areas, we also have this for psych as well. So with primary, this is before any type of manifestations happen. They seek to reduce the incident rate of new cases. This can also help to prevent or maybe even delay any onset of symptoms in patients who are very vulnerable. So this is where we can teach coping strategies to help them prevent anxiety disorder for those patients who are very vulnerable. When we come to the secondary prevention, this is when you want to reduce the number of new cases and old cases of some of the psychiatric disorders. So we want to identify, screen, and give a lot of quick prompt treatment. It does not stop the actual disorder from starting, but it may delay or slow the progression. For example, the patients that you normally see the most in the ER, those would be your secondary, because we weren't able to prevent it, but now we're taking care of that, identifying, giving a prompt treatment for those patients. With the tertiary, this is preventing progression. It's also known as your rehabilitation. This is where you start to preserve and or restore patients to their some type of functional ability to be out in the community. And this way we could help them to avoid any type of loss of job, any family interruptions, and hopefully prevent any kind of harm or death. Example, this would be working with a patient and teaching them or helping them know how to pay their bills and manage their finances. Outpatient psychiatric mental health care. There are some different types of providers and care that are given, and they have a nice comparison outpatient versus inpatient care settings on page 71 in your textbook. There's a table there, table 4-1. The assertive community treatments, when you hear that, it's kind of a little bit scary thinking of assertiveness out in the community. But what they do is they provide intensive community services to those individuals with some type of serious persistent mental illness who live in the community but still require extensive services to help prevent admissions or repeat hospitalizations. When we're looking at the outpatient psych units, you have primary care providers. You'll also have your specialty providers, your patient-centered health and medical homes where they live in a group home, your community clinics, and some type of psychiatric home care that's out there. One of the differences that you see is with outpatient, there's the supervision is intermittent. It doesn't happen all the time. They pop in and out and check on those, and they really look at those individuals becoming independent, having independent living and an independent living environment, and knowing how to take care of themselves and prevent any kind of issues, safety issues, and prevent any risk. Whereas your inpatient, they're under 24/7 supervision. They have to have that therapeutic milieu to help them with that nice healing environment. So it's a little bit different when you look at those two treatments. You want to stable and improve their level of functioning in the community when it comes to outpatient. However, in the inpatient, they're during a crisis or peak of the illness, and so we're trying to stabilize them to get them back into the community. And then they list different interventions, and you can look at those on page 71 in your textbook. Sometimes we have what we call partial hospitalization programs, and this is individuals who don't need to be there all the time, but maybe during the day they become weak. Let's say you have a severe alcoholic, and when the wife, he states to the nurse that when my wife leaves for work, I'm so afraid I'm going to start drinking again. The urge is there, and I just can't stay away from that bottle. And I'm afraid I'm going to do something. And so they may have this individual go to partial hospitalization, where during the day when the wife is at work, he is at the hospital, and then he comes home in the evenings when she is. Other type of venues can be telephone crisis counseling, where there is actually someone on a phone to help those within a crisis. Telephone outreach, helping individuals know where to go for help. We have the internet, and there's some crisis centers who are actually on the internet who will work such as suicide crisis hotlines and things like that. And then telepsychiatry, where patients can call in and talk to their provider, a healthcare provider in mental health. Nurses in the outpatient setting and out in the community, they have to be quite strong in their skills and autonomy, and have a lot of competence in cultural differences, not only ethnically, but different groups out and about, and genders, and have a lot of knowledge. Also, they have to know what resources are out in that community, and they have a lot of autonomy. So this does involve enhancing a lot of patient strengths in their day-to-day activities and settings. They can help individualize care to fit the patient, and allows the patient and their families to learn new ways of coping with systems and in difficult situations. This includes empowerment and also self-management as well. During these visits includes a psychosocial assessment. They're going to be doing case management, promoting a continuation of their treatments, and there is a lot of teamwork and collaboration, talking to members of the team about different individual patients. The biopsychosocial assessment is on page 71, and it gives you a little description about that. And also on that page, they talk a little bit about treatment goals and interventions for those individuals living out in the community. So a breakdown of the assessment, biopsychosocial assessment. You have housing adequacy and stability. So if a patient maybe faces fears of being homeless, it's not possible to focus on other treatment issues. Sometimes there's income or source of income, so the patient must have a basic income, whether from an entitlement, a relative, or some type of other source. They have to be able to obtain necessary medications, and also anything they need to meet their daily needs for fooding and clothing, to be able to go out into the outpatient community setting. Family and the support system is very important. The presence of a family member, maybe even a friend or some type of neighbor who supports their recovery, can gives a person, the nurse, a contact person, and also they have to have the patient's consent as well to be able to work with this support person. Substance abuse history and current use. This is often hidden or minimized during hospitalization. Substance abuse can be really a very destructive force, and so undermining medication effectiveness as well. And it can interfere with community acceptance and procurement of the housing where they can stay there. Someone may say, I'm done with you using these drugs. You come in, you don't know, you're so messed up. It's, you need to get out of here. You cannot stay here. Physical well-being. any factor that increases health risk and decrease the lifespan of individuals with mental illness include, something like decreased physical activity, smoking, medication side effects, and someone not going in for, routine health exams as well. In the ER, we think about triage and stabilization. These individuals are usually seen on a voluntary basis when they come in. Sometimes, though, it may be suggested or maybe even required for an evaluation. People who suggest maybe family, friends, law enforcement, or medical personnel who see them out and about and realize they do need help. They talk a little bit about this on page 73 in your textbook, talking about the crisis stabilization and observation units that are also available. For inpatient psychiatric care, admissions are usually those individuals who are suicidal or homicidal, so they may harm themselves or someone else. There's a threat, so they will usually get a direct admission, or they may come in through the hospital emergency department. What qualifies them for admissions usually is that they are a danger to themselves or others, or they're not able to fulfill their basic needs on a day-to-day basis, or they have some type of gross impairment of judgment, putting them at a risk a risk of harming themselves, or based on their inability to be able to even just protect themselves from harm. There are some admission options. This could be direct admission, again, as I said before, or hospital emergency department. They can come through there. Again, they are at risk of harming themselves and others, or they're unable to fulfill those basic needs. Sometimes patients come in on a voluntary basis or an involuntary basis. When we think about discharge is going to be based on improvement of the patient over the days that they've been there, and taking their medications on a regular basis to prevent readmissions. On page 75, there's a box there that talks about patient rights and what's included in those, and it is box 4-2. And they still have rights to refuse medication if they require restraints. There needs to be specific limitations per policy for those. Remember, we should use the least restrictive intervention and treatment for these patients. They do have a right to have visitors and to have a safe environment. They can still make phone calls. Sometimes people think, oh, they're in mental health and they can't call anyone. Yeah, they can use the telephone. They can reach out to support people. And so they do have those rights, and lots of times people don't think about that, but it's just like as if they were in the hospital, because again, they do have an illness. And you can read through this slide. It's pretty straightforward, and they talk about teams, working as a team on page 75, and that is very crucial when it comes to mental health. You have to work as a team and communicate and keep each other informed. We've heard about the term therapeutic milieu, and that's making sure everything is safe, the surroundings and the actual environment, physical environment around the patient. So, and this can include managing behavioral crises, includes the safety, suicide risk, making sure that we're using prevention measures, and keeping everything clear, the patients are safe, and all harmful things, so to speak, are locked away. And it's the safety milieu. Here you see some of the list of things that are included in nursing care. And one of the things that you'll notice when you go into mental health are the therapeutic groups. They have very structured activities, community groups, family and special groups. They have daily meetings. They greet new patients. They share unit activity ideas with one another. There's different topics that they can share, explore, explore each other's problems, their own problems, and engage in some type of communication. Usually hearing that others have issues just like them or that are similar makes them not feel so alone. It can be very, very therapeutic for them. Okay, I'm going to let you go through the response questions. And here's the second one.